start with the first talk, which is entitled From Medical Image Computing to In Silico Trials of Medical Devices. And Reed and I really made a very good case to the combination of both AI, medical imaging, and importance in the context of medical devices. And that's essentially the main context of the InSilex project, which is a Royal Academy of Engineering chair in emerging technologies, where we are trying precisely to study the interaction between all of the different technologies. And I'll try to report some of the work we're doing and the vision behind. So the medical device sector is roughly a $500 million market, and is acting in a quite changing demographics where we have aging going on, but also in particular for the UK is quite important because there is quite a a large industry in that context. There is a 5% increase year on year of the sector, and there is particularly interest in the context of both cardiovascular orthopedics devices, and there's also quite a lot of work in medical robotics going on. However, there is a number of challenges that are affecting the sector and drivers as well that are making it grow. I mentioned about aging. I mentioned also the changing lifestyle. There is also a complexity on medical devices that is growing, and a technological convergence, which is making devices more and more complex, and therefore we need to have better ways to assess and develop them. But there is also quite a lot of downfalls in that context, including increasingly reported serious adverse events, which has reduced the trust in the sector and therefore the shareholder values from these companies. And there is a need for actually rationalizing more and more the R&D cost and reduce the time to market. So if we compare this sector with the automotive sector, which is about 4 times larger, we see that over the last 30 years, there has been an impressive change in the technology and the types of automobiles that, for instance, we utilize. And we went from a sector where we used to utilize a lot of experiments, so these are wind tunnels and the old way, to now being done. So so I was explaining how this in the automotive sector has changed. The use of modeling and simulation has changed the way we develop man-made objects like cars, but also any other type in many senses. We also use virtual prototyping and even AI in the context of self-driving cars. Per counterpart, if you look, for instance, to the medical devices, is still largely incremental. And if I show you the same 30 years, 30 years to today, years of development on a particular device that I will talk later in more detail, you'll see that there is still a bunch of wires in large extent. And what is quite, crying out essentially for change is the fact that after the 30 years, we still have large complications rates, large mortality rates in relative terms. So one would say, well, why cannot we use the same technologies to actually develop devices so that we can, for instance, computationally look at ways that we can insert those devices and understand their behavior. So this is what the InSilex project is trying to do, is actually see how we can disrupt this life cycle of medical device development, which has a number of phases, from the conception of the device to the optimization of the design, to then assess the product in potentially in virtual populations, to then redesign or understand the root causes of failure modes once we go to market. And the interesting thing, and also particularly calling our attention, is that in spite of a massive growth rate, so we are talking about medical devices and drugs for which the same ideas could apply, between 5 and 6% year on year, which actually is larger than the automotive industry growth at the moment. Yet the number of devices that are going through FDA or CDA approval is actually stagnated, and both medical devices and drugs has stagnated over the last 10 years or more. So clearly we have a demand which is growing, but not necessarily providing the best and the latest technology due to this problem. So the ambition basically is, what would happen if we could utilize imaging, modeling, simulation, AI to actually improve the way we develop those devices? And we could essentially use this for what is called the 3 Rs, for refine, reduce, and replace conventional trials, by actually thoroughly understanding devices and running them on virtual populations, and potentially under operational uncertainty as well, which is more realistic that we can do nowadays. So imagine we would be able to have a library of anatomical models of whichever organ. I'm using here aneurysms as an example. We could then virtually implant devices and study, for instance, how the hemodynamic is changing in different anatomical conditions. We can do the same in terms of looking at different operational regimes, like rest and exercise. And we could also look at different device configurations and different device designs and what their performance is for all of those. So this means we could develop virtual trials, virtual populations, where we could study thoroughly a particular device in different anatomical regimes, different physiological regimes, and each of those elements becomes what we know as a virtual experiment. So let me now go in a bit more detail, explaining this in one exemplar, which only tries to be an illustration of a much wider concept, but to be able to ground it in a concrete problem. So the example I showed you already a bit before is brain aneurysms. This is cause of hemorrhagic strokes, which are about 20% of all the strokes we know. People don't really know exactly why these aneurysms are generated, what makes them grow, or why eventually they rupture. But what we do know is they tend to like to be built around bifurcations in the circle of Willis in the brain. And that once you detect that one of those aneurysms is present, you have quite a lot of dilemmas. One is whether you need to treat or not, and the second is which best treatment you could apply. And there is a number of treatments, going from clipping, which is a very invasive surgical procedure, to endovascular and minimally invasive procedures like coiling with a stenting, or flow diversion. Now, what we have worked over the few years, probably about 15 years now, is in developing tools for interventional planning. And we develop techniques that allows you to assess parameters that have to do with the risk of different types of interventions, so that you could compare them and help to aid the decision of what treatment to go, by understanding the potential life expectancy that you're adding to the patient, in comparison, on the other hand, by the risks that you're adding through the intervention procedure itself. We also develop tools that you can utilize for then planning hemodynamic changes that are induced by the presence of devices, therefore complementing medical devices like imaging systems with information that they cannot, in an interventional setting, easily provide. And that led to the development of a number of pipelines that allows you to go from images all the way to do segmentations, develop mesh generators, setting boundary conditions, solving physics equations like flow, and then visualizing those results of the simulations in what effectively are virtual images, and derive from those parameters that can be used for decision making. Now, what we found out, or what we realized, is that you could utilize the same pipelines with a number of important improvements that you need to do subsequently for virtual trials, as I mentioned before. So, but still in the context of interventional planning and interventional and diagnostic problems, what you can do is, if you are able to have pipelines which are effective to run at really larger scales, you could develop high throughput analysis pipelines from digital databases like hospital databases or population data sets, where you can extract information of a very large phenotype of both morphological, hemodynamic, but also complementing that with lab and clinical history, and therefore develop those systems for decision making that I mentioned before. Now, just to give you a pictorial index of what could my talk be today, but I will go to only one part of that, is we've developed algorithms to go from images to segmentation in detail. And this is something where we're working again a lot more now with new techniques based on deep learning to be able to do automatic analysis. So we want to be able to run these data sets on tens of thousands of images and be able to run reliably segmentation pipelines, and that's an aspect we are working on. We also are able to do morphological analysis and morphodynamic analysis. This is important because shape and dynamics of shape have information about disease and about potential treatment outcome. We develop also pipelines for doing numerical simulations, particularly blood flow and blood clotting, and I'll comment that a bit. And we also develop techniques to do virtual interventions, particularly virtual stenting and virtual coiling, so that you can simulate the different types of intervention. I will talk today mainly about virtual stenting, but we've done quite a lot of work as well on virtual coiling. So let me focus primarily on perhaps the least familiar part for this community, the part that is less medical image computing, because to some extent, what I'd like to explain is what can we do with the sort of techniques that are going to be discussed in this conference if we were able to scale them up really at large scale. So back in 2012, when we were doing quite a lot of this work, there was a guideline by the American Heart Association and the American Stroke Association, where they started reviewing the evidence in different type of biomarkers. And it was quite telling for us at that point that for the first time, these guidelines indicated that in addition to just the basic biomarkers that were used at that point, which are age, health status, and size, and location of the aneurysms, morphological parameters and hemodynamic parameters of aneurysms were becoming to be more and more relevant. And there has been only growth in the realization that those are important components. So we developed the pipelines that I mentioned before. And that there is a lot of science behind that. There's probably 40 journal papers that back all the work we've done over the last 15, 20 years. But just to give you some of the main highlights, you need to make very careful assumptions regarding your simulations to be reliable. And those assumptions were tested very, very thoroughly. So we did quite substantive sensitivity analysis where we looked at how, for instance, parameters that are relevant, like wall shear stress, were depending on the morphology of the aneurysms, the type of assumptions we do on the modeling, whether we use Newtonian or non-Newtonian models, how they were sensitive to inflows and outflow conditions. We also, and one of the main conclusions there was actually that the main source of variability was anatomy. So having very accurate segmentation algorithms was actually quite an important element of that pipeline, and that was published back in 2005. This work. So it's quite a lot of work we put in that. We also looked at the difference of image and modality. So what happens if I create the same model on the same patient using 3D rotational angiography, which is a technique you do have during the intervention, versus if you do that with computed tomography angiography, that you only have it preoperatively, but usually not in the follow-ups. And there are major differences. So 3D array tends to be, is isotropic. It tends to be higher resolution. So you miss parts. So you have under-segmentations, you lose some vessels, which, as you can imagine, for fluid dynamics is important. And you also have changes in aspects which are quite important in the features of the aneurysms, like the neck area, for instance. So we did quite some detailed analysis of all of those parameters, comparing, in a database that we had both rotational angiography and CTA. We did a head-to-head comparison, and we came up with a number of indexes that, again, were critical for that, and also how you should design all the biomarkers in order to be less dependent on the modality by utilizing, for instance, relative quantities rather than absolute quantities, and also using semi-quantitative parameters rather than fully quantitative parameters. We also looked at how you could use those to actually, those parameters to characterize flow and characterize them in different locations of the aneurysms, and characterize them not only statically, like with mean average flows, but also dynamically by looking at the variability of flow over the cardiac cycle. And that led us to understand also how some of those parameters were related, for instance, with rupture. So what you show here is 4 different flow types that we came up with for clusters of flow, and where it's clear that one of those has more likely to having non-ruptures, while some of the other ones are more split. And also we looked at things like, for instance, the impingement size of the flow jet into the aneurysm dome itself. And what we observe is that when you have a smaller jets of impingement, that tends to be higher correlated with rupture than when you have a very, when you have a concentrated jet is more dangerous, let's say, than when you have a much wider gentle pressure jet. We also did a number of studies where we looked at how flow correlates with risk of rupture in different flow patterns. So we found that, for instance, in a particular study with different types of aneurysms, which were all terminal aneurysms, so all at the end of a vessel, this particular flow pattern was, there was these 3 patterns that were present primarily, but that this one was the one usually most associated to rupture. So this is quite important, because understanding what hemodynamic drivers lead to rupture is, as you will probably imagine, critical in then deciding objective functions to optimize devices, because you're trying to change that pattern and put that into a pattern that is less prone to rupture. The other thing which is quite important is that we tend to do all of these simulations in pretty much, even if we do transient simulations, we tend to do that with boundary conditions which are in one time point in the life of that patient. And we as individuals are changing all of the time our physiological conditions when we run, when there are seasonal changes, when we are sedentary. So one thing that is becoming more and more important is how we link those technologies with wearable sensors so that we can actually inform the highly detailed anatomical models that comes from imaging with highly detailed temporal models that as they come from wearable sensors. And then the other question is how you go about bringing the physiological variables that you measure, peripheral from the body with wearable sensors into boundary conditions in specific locations of your aneurysms, which is the part that you're actually interested in studying for devices. So there is a whole study about how you propagate boundary conditions and how you develop multi-scale models that are detailed in the area of interest, but they are sort of lower dimensional and faster and more efficient elsewhere. So one of the things we did in that context is we worked in a European project that I had the pleasure to coordinate with quite a lot of partners around Europe. We had what we call a sub-study, which was called a Lido sub-study because was done in the Lido island in Italy, where we collected about 100 subjects, which were all elderly, of which some of them had mild cognitive impairments and some of them were controls. And we did physiological measurements with wearable sensors for 24 hours using Holter in a number of variables, including also gait and other parameters that we are not using here. And this is just the descriptive analytics from all of those subjects in the study. But what we did is we also took measurements of blood flow and blood pressure, and we developed using machine learning, and in this case using Gaussian process models, sophisticated models of the boundary conditions for flow that allows us to understand for a particular individual how does the pressure wave change over 24 hours, and therefore what is the average pressure wave, but also the uncertainty that we have as marked there in gray. And we also made we could parameterize this curve so that we incorporated the elements of body mass index and age into these models. So we now have generative models where we can automatically generate boundary conditions for specific ages and a specific body mass index. So what we have now is a mechanism, is a generative model to synthesize flow waveforms in ways that are consistent with things we observe in real patients. And why that is important? Because what we observe is that actually physiological variability can have an important factor. So they are related with systemic conditions, but also with lifestyle, with aging potentially as well. And we could look at, for instance, how flows in the same aneurysm depends on whether you're in rest conditions or you're in exercise conditions. And we did some studies purely looking into biomarkers of risk of rupture, where we observed that although that variability had limited effect in certain parameters that are used in the literature, like time average wall shear stress parameters, they actually have quite some large effect in instantaneous oscillatory shear index and transient wall shear stresses, which are actually used quite a lot. And that the main thing that although these parameters can be on time average way insensitive to the physiological regime, if you look at aspects like the wall shear stress and you look at the harmonic content and the directionality of the wall shear stress over the cardiac cycle, that actually dramatically changes between with or without that physiological regime being accounted. And we think that has to do as well with how this affects some of the inflammatory processes on the wall, and therefore it can have quite a major risk. And in fact, we show that in a small database of about 20 subjects, about 4 of them flipped their status from rupture to non-rupture risk just because of the change in these boundary in these physiological regimes. A small set, but nevertheless worth mentioning. So we also developed techniques for doing stenting. So I don't have time to go into a lot of detail in terms of how different vessel geometries, operator skills, can lead to different outcomes, even with the same device and the same geometry, and also how malposition of the devices can generate in-stent thrombosis, for instance. But what I like to show is that, when I was doing this work some years ago, one of my interventional radiologists from Switzerland, I asked, Daniel, how do you actually think about these devices? And he said, well, we normally put a stent in a particular direction that will reduce the blood flow going to the aneurysm, producing a stasis and therefore flow, blood clotting. But there will be a still low resistance distally to the vessel, and that will generate that there is still a flow going through the struts of the stent down, so I don't close this vessel. So, okay, that's fine, but how do you know that you need to put it that way and not the other way? Or you need to put two? So, well, that's experience and, lots of other things that he wasn't able to easily articulate for me, and that he recognized for new people who are new interventionists becomes challenging. So what we set forth is to do the following. So what about if we develop a system where we can actually test all those different alternative treatments, and we look at how the magnitude of the blood flow changes, the pressure drops, the wall shear stresses, and you can make up your mind. So I said, well, that would be brilliant. So we came up to develop techniques now to do virtual device implantation. So techniques which are very fast using simplex and deformable, simplex meshes and deformable models that try to capture some of the physics, but without being fully structural mechanics models, so they can run within a minute. We compared those, so how you validate, and the other thing that comes about is how you validate such technique. So we had to go developing experimental systems where you could put different types of stents, and we had a pump with a circuit where we could compare a virtual with a real circuit. So this was done with 3D printing for making, digital replicas of and micro-CTing, the devices, and generating a CAD model of the devices and a physical model of the stent, and putting a physical model of the stent in the physical model of the aneurysm, and a virtual model of the stent in a virtual model of the aneurysm. And then what you can do is compare, for instance, our fast virtual stenting with other techniques, which are finite elements, which are, take several, many hours compared to the fast virtual stenting, but are supposedly more accurate. And what we found out is that for most of the purposes we're interested in, they're equally applicable. And then in terms of the hemodynamics, the hydraulic circuits that I showed before, what we had to do is compare the virtual sort of reality with the real reality. And this is for two different stent designs. And then looking at things like time dilution curves, where what we observe, what you see there in pink and in green, is a sample volume in the middle of the aneurysm in the real and in the simulated one, and showing the time dilution curve, so the amount of dye as a function of time, and you can see that they're pretty much spot on. The blue one is a sample at the feeding artery, and we use that for control, for reference. So incidentally, for those of you more curious on that, as you can imagine, this is not just solving flow equations, but you also need to solve the transport equations, and you need to model the transport, propagation through the bloodstream. And then you need to do a digital ray casting to actually mimic the X-ray and then have the same viewpoint to the real X-ray and compare both, which is basically what we've done in that exercise. So then you can have these sort of things. You have a device, a real aneurysm with two different types of stents, stent 1 and stent 2, and now we can compare, different types of relevant parameters like sluggish flow, residence time, so all the parameters which are relevant for device design. And then you can go and show that into, do that in a real database of patients and start studying how certain devices perform on a small population set. And you can draw conclusions for those which are, relevant from a clinical point of view. Now, I explained you before this first dream that we had, some years ago. Now, one thing you will notice is that we had only modeled physics so far, but actually what will be very interesting is to also model biology. So add to that flow the biochemistry, because ultimately we are putting those devices to produce a stasis and produce clotting, and that's ultimately what will dictate the quality or not of our device. And it has been shown in the literature that it's not enough to rely on radiological or angiographic success, or what is called angiographic occlusion, which means that you put a stent, you see that the aneurysm is not visible anymore in an angiographic study by putting contrast agent and seeing that the contrast doesn't get into the aneurysm anymore. Well, the only thing you've shown there is that there is no contrast coming in, but you don't know the quality and the type of clot that has been formed. And it has been shown in the literature that there are cases where with a delay time, those aneurysms rupture, and people don't really quite understand why that has happened. And we believe that that has to do with the quality of the clot, and you know, together with a number of other authors that have reported similar findings in the literature. So we had to develop a technique that actually allows us to model the biochemistry in addition to the physics. And the idea is, you know, I don't have the time to go in detail on this here today, but the idea is that there are two types of clot. There is what is called the red clot and the white clot. And the way to understand it as engineers, that most of us probably are, is that the red clot is like a gel, a gelatin that you can redissolve by, you know, additional pressure, by additional, you know, things that happen in the aneurysms. While the white clot is a combination of, the white clot contains also a lot of platelets and fibrins that generate a mesh together with the thrombin and make sure that that thrombin gets solidified and gets kind of in a scaffold, so it doesn't re-dilute easily again. So what we came up with one of my students, that is a chemical engineer, he developed together with some collaborators a model for understanding the proportion of red clot and white clot that is being generated. And what we can do now is actually provide density maps of the clots. And to be frank and helpfully, what I show here in red is actually the white clot, and what I'm showing here in more whitish is actually the red clot. So it's kind of inverted in terms of color scale. So be mindful about that. And we compare that with physical experiments where our predictions show similarities with those results. I want to show a last thing, because I recognize that we have had some technical issues and I'm running behind schedule now. But one of the things we are very, very excited, and we recently made that available as a preprint, and is currently in review in a major journal, is what I consider one of the first in silico trials fully validated. And what we have done is what we call FDPAS as trial. What this trial we've done is we've replicated the populations using a large database we have of aneurysms of 3 conventional trials that have been published in the literature: the PUF trials, the ASPIRE trial, and PREMIER trial. So what we did is we are not using the same patients as those. This is not a twin trial, but what we know as a chimera trial, which I haven't introduced, but is essentially we find a matched population and we build a digital model for each of those members of that matched population. And what we have shown is, in a nutshell, that by utilizing these in silico techniques, we could replicate the results of the 3 previous conventional trials and explain failure cases that they couldn't explain, therefore demonstrating that in silico trial is not just a replica and therefore can save time and risks, but also can provide additional insights. So this is, for instance, one of the trials that we compare to the PUF trial, and this trial took 8 years to decide from design to publication, with 6 years of recruitments just to get 108 patients. Okay, and we could do the whole trial in less than a couple of years, and that was the first time that we were doing it, where we had to develop a lot of tools on the way. So this is, again, just some results. I mean, we work with epidemiologists and we're interventional surgeons, so we make sure that from a clinical trial design point of view, they're consistent. And these are just some of the results, which again, and the benefit of time, I'll probably skip. But I gave you the main gist of it in terms of ability to save time, save risk, replicate results, and provide additional insights. So in summary, computational imaging and physiology can be used for the management of brain aneurysms. This technique is descriptive. It can help to understand the disease, but is also integrative and predictive because it brings different modalities together and allows you to do predictions of scenarios you couldn't actually image. translation clinically is not just about bringing this technology, it's about validation, validation, validation. And I haven't had the time to show all the details of validation work we've done, but trust me, it has been quite thorough. And I gave you a couple of examples of areas where we did a bit of that. And also that industrial translation is fundamental to actually supporting the medtech industry, because, there is a lot of technologies, and probably you also already saw a few through the presentation, but there is, way more of those. And unless we bring these multiple technologies together, the challenges of building the next generation of medical devices and medical technology in general is going to be massive, both in the complexity of the devices, but also in the time to market, and therefore the cost that we will be paying for being able to, to enjoy the benefits of those technologies. And with that, I'd like to conclude, giving a big thanks to quite a large team. These are more the historical team and some of the current members. Lots of the work by Tony and Ali more recently, but we have now quite a large team that is also working on the next wave of work that is coming up. So stay tuned. So thanks a lot.